space right here, and then paraglottic space will be coming down here. All of that is included in this volume. And then you can see them, covering the level 2, 3 nodes right here in this patient. Now you're coming down to the area of gross disease. And so you can see a very bulky tumor, essentially involving the glottic larynx, and then really, stretching just transglottically. You can see anteriorly into the anterior mediastinal structures. Down here, you can see the thyroid gland is completely obliterated. So now you can start seeing in the red is the CTV70, and you can see this is now encompassing the primary tumor. This patient had bilateral level 3 lymph nodes right here. So you can see that those are being covered. And now you can see that here the 60 gray volume is covering essentially those 5A nodes, in this patient. Coming down here now, below the thyroid cartilage, or right at the level of the caudal end of the thyroid cartilage. Again, you can see that, these volumes are being covered in this patient, going anteriorly almost up to the skin. So, a point for these really complicated patients. So you can see when I think of adding bolus, I usually only add bolus around the stoma, especially when I'm going to start going to doses of 60 to 66 gray. But you can see that my volumes are going to the skin even way higher up here in the neck. And so when I tell the planners to optimize, I'll usually tell them, especially with, rapid arc-based planning, that, a VMAT plan, where I'll tell them to optimize by contracting, usually 2 to 3 millimeters from the skin surface. And with a VMAT-based plan, because you're doing these helical arcs, you're going to get a robust skin dose in these patients. And if there's ever any doubt, you can certainly put an OSLD on the very first day to see what that skin dose is. In this patient, now you can see we're at the level of the trach. And so there's bolus right around the stoma in this patient. And again, you can see this very, very bulky disease. As I mentioned, the thyroid gland is completely being obliterated here. And you can see now, all this paraglottic disease down here in this patient. So all of that getting 70 gray. And then coming down here, you can see the tracheostomy here. You can again see 70 gray volume. And then here's I'm sorry, 66 gray volume. And here's the 60 gray volume. And then similarly now coming down here in the anterior mediastinum, again, when you start seeing patients that have significant involvement of the anterior mediastinum, you really have to treat this volume all the way very close to the skin surface. And so you can see here, this is right in the parasternal region, right above your manubrium. You can see that, these volumes are going all the way out to the skin, because really there's no anatomic barrier here, especially when this patient already has gross disease right here. And then you can see that here, I did make an attempt to carve out the esophagus, fully well knowing that my esophageal doses are still going to be fairly high, but I wanted to try to spare the esophagus in this patient if I could. And again, now you can see, again, just coming down all the way in this patient. And you can see, because this patient has superior mediastinal involvement, my mediastinal volumes actually are going all the way to the bifurcation of the trachea. So there, I'm going down here, to the carina and covering the precarinal space in this patient. And here's what these volumes look like. So I wanted to again show you some coronal and sagittal views. So here you can see the coronal view, very, very bulky larynx cancer with bilateral lymph nodes here. And you can see that just given the location of the larynx cancer, it makes sense that this patient has superior mediastinal disease just from the location of where this larynx cancer is. And now you can see the elective volumes here. So you can see, now treating generous portions of that superior mediastinum to 60 gray. And then you can see here on the sagittal slices, then treating, the higher level 2 lymph nodes here to 54 gray. And so here are some volumes. So any questions about these larynx cancer patients that I can answer before we move on?
We do have a question. So since the superior mediastinum goes low, right? How do you advise to avoid the lungs if they don't have like a VMAT? Like, cause I see like some institution like try to divide it, or like do IMRT up
You got it. I was just going to say that, Rochelle. So if you guys remember the
Mhm.
early days, if you all remember the early days of IMRT, we used to actually split the fields, right? So you would treat intentionally the area, you'd put the match line at the larynx and treat the volumes above the larynx, with a VMAT plan, and then match the volume at the larynx with a single on-phos photon field, very similar to the days of 2D and 3D head and neck radiotherapy. I think that that's, if you don't have VMAT, I think that that's certainly reasonable. I think it always becomes a little hard when you're trying to put that match line right through tumor. And so, you can certainly do it. You can feather that match line over time, but you can certainly, I have previously done exactly, with a CT-based plan where we feathered the junction and have done the inferior part APPA with some kind of fluence editing and done the cranial part with intensity modulated radiotherapy. But you're absolutely right. The other thing that I often do is that, sometimes, for these really long fields, we will do multiple isocenters. And for the inferior isocenter, what I really like doing is partial arc. So, besides head and neck cancer, I treat hematologic malignancies. So it's very common for me to treat these kind of volumes in my Hodgkin's lymphoma patients. And for those patients, we typically will use partial arcs in the chest. Because of exactly that, because wanting to keep the lung dose low. So what I typically like is what I call, I think MD Anderson does a fixed field butterfly technique where they have typically 3 partial arcs anteriorly and two partial fields, fixed fields posteriorly. I do the same approach here with arcs. So I'll typically have 3 anterior partial arcs and then 2 posterior partial arcs. And they essentially look like the wings of a butterfly. So you're able to spare that lateral, the lateral aspect of the lung. So essentially you're going to spare these, very well spare the lateral aspects of the lungs and keep a reasonable lung DVH. The other caveat that I will say, when I treat these patients where I'm treating mediastinum, I'm always going to make sure that my simulation CT goes all the way down to mid-liver so that I can accurately have a lung DVH and watch that lung DVH. And I'll typically use the same parameters as you use in locally advanced lung cancer. So trying to keep that V20, certainly below 30, trying to keep it to around 25%, and then trying to keep the V10 to 40% and the V5 to 55 to 65%. So it's similar dose constraints in these patients. Any other questions? All right, if not, let's move down to thyroid cancer. So I'll start by saying the role of radiation in thyroid cancer truly is controversial. And I think that this is so institution specific. There are some institutions that treat a lot of thyroid patients, others that don't. And I will say that, UCSD is kind of solidly down the middle, that we don't really have a large thyroid volume here. But we can talk about some of the indications for the role of external beam radiation in thyroid cancer. So yeah, I split this up into kind of routine, selective, and rare. And so routine, I think we already all know, anaplastic thyroid cancer, and then poorly differentiated thyroid cancer. So I will say PDTC is a relatively newer recognized histologic variant of thyroid cancer in the last 10 to 15 years. And I wanted to just make a point, these patients also do poorly. So as we all know, when you have a patient with anaplastic thyroid cancer, median survival is on the spectrum of 12 to 18 months. For a poorly differentiated thyroid cancer, median survival is on the spectrum of 2 to 5 years. So this cancer is often lethal with very high risks, very similar to anaplastic thyroid cancer, risk of both local recurrence and distant recurrence. And so just something to be aware of if you see these patients. I think that all these patients certainly warrant adjuvant radiotherapy in the postoperative setting, even in the setting of an R0 resection. I think other thyroid histologies where you think of adding external beam radiation, certainly medullary thyroid cancer, this is selectively used, especially because medullary thyroid cancer tends not to be radioactive iodine responsive. And then in terms of differentiated thyroid cancer, here are some of the indications that I think of considering postoperative external beam radiation. I think the first setting certainly is, patients who have, RAI refractory disease. I think patients who have had multiple recurrences, especially if they're going in for their second and third surgery, and particularly if those relapses are in the central compartment, I think those patients do benefit from adjuvant external beam radiation. And then I would say patients who have an R2 resection, so where you're leaving gross disease behind. And generally, as you can imagine, most surgeons will leave gross disease behind in the central compartment because the tumor is invading into one of three structures. It's invading into the recurrent laryngeal nerve, it is invading into the trachea, or it's invading into the esophagus. And so, when you start seeing, gross disease in these regions, I think those are the times where you really should consider adjuvant radiotherapy in those patients. And then finally, patients who, if you follow thyroid cancer, you can certainly see that there are patients who well into their second and third decade after a long-standing history of a well-differentiated thyroid cancer, that their disease starts de-differentiating and becoming more aggressive. So if that's the case, then you can certainly consider adjuvant radiotherapy. One caveat about the use of radiation in differentiated thyroid cancer, I will say that unlike most head and neck cancer, where you want to, when you treat a squamous cell carcinoma of the head and neck, you're going to see involution and resolution of that disease with radiation or chemoradiation. Versus, especially in differentiated thyroid cancer, I think radiation generally is tumorostatic. So meaning that these tumors don't necessarily involute. In fact, I would say the more well-differentiated the cancer, the less likely that that tumor is going to involute. But the goal of radiation in this setting is really to arrest further progression of disease, which you can imagine becomes important when you're dealing with high real estate in this area. So here, I just borrowed this picture. This is actually in Dr. Lee's most recent contouring book. I just wanted to kind of show you a lot of the critical anatomy that, was there a question? I'm sorry, did I miss something? Okay. So I just wanted to point out some critical anatomy here in the central compartment. So you can see here's your thyroid gland, here's your trachea, here's your esophagus. Right around here is the tracheoesophageal groove, which is oftentimes where these tumors can extend when they extend outside of the thyroid capsule. And then you can see that there's multiple vessels and nerves that lie in this area, which make surgical resection here very, very tricky in these patients. So I'm going to share two examples for you today. The first is a patient of a differentiated thyroid cancer. So this is a 69-year-old woman who had a long-standing history of thyroid cancer, who had a Hürthle cell carcinoma of the left thyroid lobe in 1992, underwent a hemithyroidectomy with no adjuvant therapy, and then did well. And this is the other thing that I wanted to, the reason I picked this case is to kind of illustrate the point that differentiated thyroid cancer can be a lifelong disease for patients. And so here you can see this patient relapsed well into the second decade, of their cancer, after their initial cancer, where this patient relapsed with a separate thyroid cancer, so now a right thyroid lobe cancer, where this cancer was a papillary thyroid cancer. And so this patient on imaging had extrathyroidal extension and right cervical adenopathy. This patient underwent a right thyroid lobectomy and a right neck dissection of levels 2 to 5. And at the time of surgery, there was disease noted in the TE groove. There was frank tracheal and esophageal invasion. And so, this resection was an R2 resection. There was disease left behind right by the tracheoesophageal groove in this patient with positive margins. One lymph node was positive out of 12 in that neck. Oftentimes, thyroid cancers, more and more these days now, we're testing them for a variety of cytogenetics, and this patient had BRAF positive disease. And so this patient was started on a BRAF inhibitor with dabrafenib, I'm sorry. And then about a couple of months into this molecular therapy, the patient went to MD Anderson and sought a second opinion. This initial surgery was done outside of UCSD, and now this patient went to MD Anderson for a second opinion. This patient's actually a physician. And at that time, the patient underwent repeat imaging, and at that time, they were only able to see two discrete foci of disease. They saw a disease in the tracheoesophageal groove and a superior mediastinal lymph node. And so this patient then underwent a repeat resection with a central compartment resection and a superior mediastinal resection. And at the time of surgery, they were able to excise both of these discrete foci of disease with negative margins. So really good surgery. And this patient then came to see me to talk about doing adjuvant radiotherapy because she lived in San Diego. And so what do you irradiate in thyroid cancer? And I'll say, just like the decision to treat thyroid cancer, I think the areas of irradiation in thyroid cancer are also somewhat controversial. I think things that we all can agree upon is that if you have gross disease, you're going to go to 70 gray. The areas of positive margins and extranodal extension, you're going to treat to 63 to 66 gray. And then comes in, what is that high-risk elective volume? So generally in these patients, that's going to be the postoperative bed, the tracheoesophageal groove, the central nodal compartment. So typically, which is going to be, you can see superiorly, I said, going at least to the cartilage of the hyoid bone. So levels 3, 4, 5A, and sometimes 5B. These are going to be what's going to be right here in that central compartment for these patients. Low risk volumes are going to be, also level 6, I should have mentioned, level 6, the thyroid cancer patient, you're always going to irradiate level 6 nodes here. But in the low risk volume is now, again, that craniocaudal margin around the central compartment. So typically, you're going to treat level 7 nodes, your superior mediastinal nodes here. And then how high to treat? What should that cranial border be? And I think that this is something that becomes exquisitely controversial. I usually take into account where the gross disease is and make my decision based on that. And this decision can vary. So sometimes this can go as high as the transverse process of C2. Sometimes it's at the tip of the mastoid. And sometimes it's just going a couple of centimeters above the highest involved nodal disease. So the location of the cervical disease and really the time of relapse and what my intent is all play a role in this patient.
Dr. Sanghvi, just on the last slide to clarify, when you mentioned level 7 lymph nodes, are you referring to the superior mediastinal kind of level 7s as opposed to the RP? And
oh, I'm sorry, it should be level 8, right? Sorry, level 8, I'm sorry, yes. So superior mediastinum, forget that. So this is actually superior mediastinum.
Okay.
Superior mediastinal nodes, not RP nodes, yeah.
Great.
Superior mediastinal nodes. And so here is the patient. So I wanted to show you, so this is actually a preoperative MRI prior to her surgery, second surgery. And so here you can see, I've transposed my volumes on here. I know this is really hard to see, but I wanted to show you, here's the trachea, here's the esophagus, here's the TE groove, and the disease is right here in this area. So here are a couple of axial slices, and here you can see this on a sagittal plane. You can get an idea of this disease right here, okay? So anyway, this patient then got adjuvant radiotherapy, and I'll just kind of, give you the ending. Unfortunately for this woman, she actually failed distantly very quickly after she finished radiotherapy. She got adjuvant external beam radiation, she got radioactive iodine, and then she went back on dabrafenib. So a pretty aggressive course of adjuvant therapy, and unfortunately her disease just was biologically behaving very aggressively, and she developed distant metastases. But here you can see my volumes. And this is one of those examples where I actually didn't treat level 2 nodes in this lady. I really just, started my volumes really at level 3 in this patient. I could have put a couple of slices higher. I did treat higher than this, but really level 3 onwards. And this was in discussion because this patient had seen another radiation oncologist at MD Anderson, and they had very strongly recommended to not treat the upper neck to try to spare pharyngeal and oral cavity toxicity, which made sense given how far caudally I was going to treat for this lady. So here are these volumes that you can see. You can see, kind of starting at the level of the thyroid cartilage, treating. And in this woman, I was very generous with the level 6. So really kind of starting the level 6 at the very top of the thyroid cartilage and going down. And then you can start seeing, you're treating here, a bit of the lower part of the larynx. And then here you can see, now starting to treat the trachea and the esophagus and the central compartment right here. And then here I drew in where her preoperative disease was. So given that she had an R0 resection, you can actually see that my volume's actually fairly tight. So you can see the yellow is the 60 gray volume and the blue is the 54 gray volume. And you can kind of get a sense of, the entire trachea and the esophagus in the area where her tracheoesophageal groove disease is being irradiated in my radiation portals. But you can see in this lady, because she had a superior mediastinal node, I was far more generous in my inferior aspect of the volume. So you can see here going all the way to the bifurcation of the trachea. So, treating the pretracheal, precarinal nodes and, going down to essentially to the carina. And this is what this looks like. So you can see here, both in a sagittal and a coronal view, you can see that I'm actually sparing all of her oral cavity in this woman, in just really treating a very focal volume in the lower neck in the superior mediastinum in this patient. So that's that case. I am gonna give you a case of anaplastic thyroid cancer, and I'll preface this by saying I know that most of you have seen anaplastic thyroid cancer. These to me really are, one disease site where I feel like really there are no great options. And I constantly struggle about the role of external beam radiotherapy. I know that, that the classic recommendation is to treat all these patients in the postoperative setting. I will tell you in the last 15 years, I have yet to ever finish a course, an entire course of radiotherapy in an anaplastic thyroid cancer patient. Regardless of the extent of resection, whether they have a R0 resection, R1 resection, or an R2 resection, majority of these patients, at least the ones that I've seen, have all progressed rapidly during the course of radiotherapy. So I constantly struggle with the question, just the bigger question of really, is radiation really the answer in this patients? But there are those anecdotal reports where patients do live, after postoperative radiotherapy on the order of 1 to 2 years. But I think that that's a very small minority of anaplastic thyroid patients. So here's a patient, 53-year-old woman that I just recently saw late this summer with a very locally advanced thyroid cancer. And this patient, unfortunately, at the time of when she went in for a thyroidectomy, her prelim diagnosis was actually a differentiated thyroid cancer from an outside biopsy. And so the patient was taken to the OR. And for those of you who are not aware, oftentimes if you have a differentiated thyroid cancer, a lot of places don't even do a staging CT of the head and neck in these patients. They essentially stage these patients by ultrasound. And this was one of those situations where this patient had absolutely no preoperative imaging outside of an ultrasound. And so the surgeon, this is one of our dedicated thyroid surgeons who goes in, and I just pasted the report here so that you can kind of get a sense of, this is from my consult note. So this patient underwent a left modified radical neck dissection, but as soon as they went into the central compartment, they saw extensive tumor basically invading into the strap musculature, perithyroidal and peritracheal soft tissues, and there was just bulky adenopathy everywhere. And so they actually aborted the surgery, and frozen path came back as essentially a poorly differentiated anaplastic thyroid cancer. And so, I saw this patient emergently, within a day of her surgery because she had very extensive disease and needed, rapid onset of therapy. So again, I will say these are the situations where you're not going to wait 6 weeks, to start their radiotherapy. I actually simulated this patient within a couple of days of surgery and started her radiation within a week of about a week after her surgery. And again, we can go over these volumes. So you can see in this lady, her bulky disease was really on the left side. So you can see I'm treating the left, upper neck nodes, left level 2 nodes right here. I'm going all the way to the skull base. And then on the left side, treating 1B nodes because she had level 2A lymph node involvement on the left. On the right side, just treating level 2 nodes, not treating 1B nodes because she didn't really have level 2 involvement until the very bottom. So now you're approaching at the level of the hyoid. Here's the gross disease. So here's the red is the 70 gray volume. The yellow is the 63 gray volume. And then down here, pink is the 56 gray volume. And you can see the disease. So you can see now as you're approaching into the, to the thyroid cartilage around the thyroid gland, the gland is completely obliterated by tumor. And there's a lot of extrathyroidal extension. There's extension into the musculature. And so you can see these volumes, very, very large volumes. All this is just gross disease, as you can see. And the other thing that I want you to kind of, get a sense of is that her airway is patent right here, right? So this is 1 week after her CT simulation, after her surgery, where she got simulated and started within a couple of days. and you can see that the airway is patent. And you can now see the volumes down here. So now we're kind of coming in that central compartment. You can see the entire thyroid gland, all of the trachea, all of the esophagus, everything is in the treated volumes. So you can see this was supposed to get 70 gray. This is the 63 gray volume. And then, again, generous volumes of covering the 5B nodes, and really even now going into the upper axilla, going to 56 gray. And you can see this coming down here. You can just see how much gross disease this woman has now here in the superior mediastinum. And this is what this looks like. And you can see the extent of gross disease here, here in that coronal plane and here in that, that sagittal plane in this patient. So here are these volumes. And I will say, again, this unfortunately for her and for me, this patient was able to get through about 3 weeks of radiation when she just rapidly deconditioned, and her tumor had completely occluded her airway. And, after a goals of care discussion, she was essentially put on comfort care and she passed away. But here are just some examples of these, thyroid cancers. I find them to be very, very challenging to manage, particularly these anaplastic thyroid cancers. But you can kind of get a sense of these. Generally, when you're treating these thyroid cancer patients, you're not only treating the neck, but you're almost always treating that superior mediastinum in these patients. And the elective decisions that you're kind of come in is how much of the upper neck you're going to irradiate in a patient. Any questions about thyroid cancer?
Well, thank you for that, Parag. Well, I asked some of our colleagues in Southeast Asia, they had similar experiences of patients not completing radiation therapy for anaplastic disease.
Yeah, so so more and more with anaplastic thyroid cancers now, especially as we're doing a better job of molecularly profiling our patients, oftentimes these patients do have the BRAF mutation. And so, as you all know from melanoma, the BRAF MEK inhibitors are really good at cytoreduction in melanoma. So if you have somebody who has a large volume melanoma and they have the BRAF mutation, we'll often start these patients with BRAF MEK inhibitors to get that acute cytoreduction. But the issue with this class of drugs is that most patients develop resistance very quickly. But it makes sense to use this in anaplastic thyroid cancer. So I know at MD Anderson now, they routinely test all patients for the BRAF mutation. And if they're positive, which is about half the patients, they actually start with a cytoreductive technique with upfront BRAF inhibitor for usually 4 to 6 weeks and then proceeding with surgery. And to me, honestly, that makes sense because you get to see the natural history of the disease and really then go down the path of therapy intensification in patients who are truly responders, who are then going to do hopefully better than many of our patients. All right, I'm going to end. Go ahead.
One last question. Sorry, would it make sense to? I know we're on time. Would it make sense to increase the daily dose to give higher dose of radiation for patients with anaplastic thyroid cancer?
That's a great question. I certainly think, I think that more and more, so I will say that I generally go down that path, where I will just do rapid palliation and do some kind of hypofractionation. Large volume hypofractionation always should be done carefully, but certainly these are the patients where doing something like, 60 gray and 20 fractions is very, very reasonable, where you're giving them 3 gray per fraction. But when you do that, what I would say is that I either don't include any elective nodal disease, I'm just treating gross disease, or if I'm doing elective nodal disease, I'm doing essentially 60 gray in 20 fractions to the gross disease and then treating the elective nodes to 40 gray in 20. So, but certainly I definitely think that anaplastic thyroid cancer is excellent, disease to go down the path of hypofractionation for sure for these patients. I'm going to end by talking about paranasal sinuses. So these are tough cancers, and depending on where you are, either you're going to see a little bit of it across your practice, or if you're at an academic institution, I'm sure all the paranasal sinus cases funnel up to most academic institutions because these can be so tough to treat. I think just a couple of things to be aware of when you're thinking of paranasal sinus cancers. One, I'll start kind of bottom up. They're really histologically diverse. They're literally, a dozen plus histologies. So you really need to be mindful of what the underlying histology is. Squamous cell carcinomas, make about 30 to 40% of the cases, but you can certainly see things like adenoid cystic carcinomas, minor salivary gland tumors, melanomas, sarcomas, lymphomas. Lots of different malignancies can go into the rhabdomyosarcomas. They can all go into the paranasal sinuses. I think generally for most things outside of lymphoma, the primary management is surgery in these patients. The nice thing about the paranasal sinuses is that generally the risk of occult nodal metastases is low because the sinuses don't have a rich lymphatic supply. But beware, if you have disease from the paranasal sinuses that goes into the nasal cavity or the nasopharynx or the skin, these sites are extremely lymphovascular rich and so can have a much higher risk of nodal metastases. PNI is extremely common. We did a talk previously on perineural invasion and cranial nerve path contouring. I would say majority of these cases, you're going to contour some perineural nerve for these patients. These patients, these tumors can really spread by local extension into adjacent structures. So oftentimes paranasal sinus patients will have involvement of the nasal cavity, nasopharynx, and then bony structures like the orbit. And certainly if the tumors are extending cranially, these can certainly extend through the anterior cranial fossa or the middle cranial fossa intracranially in patients. And so I think these cases are tough to contour. And I will say that even for somebody who, I do had like 50% of my time, these cases, even for me, take on the hours, on the spectrum of hours to contour, with close evaluation of the pathology, looking at the radiology, looking at where the initial disease was, and then carefully making decisions about what perineural paths am I going to chase in my contouring. I just came up with just some general indications. Again, in paranasal sinuses, the most common sites are going to be maxillary sinus and ethmoid sinus. In maxillary sinus patients, post-operatively, you're always going to cover the resection bed in any residual sinus. Superiorly, in these patients, you're going to go at least up to the cribriform plate. Inferiorly, you're going to go all the way down to the hard palate and cover the maxilla. Laterally, you're going to at least come to the midline nasal septum. And then posteriorly, for most maxillary sinus patients, you're going to cover the path of cranial nerve V2. So you're generally going to cover the pterygopalatine fossa and sometimes the infratemporal fossa. For ethmoid sinus patients, so now these patients, these are really tough to treat because, one, these tumors are essentially, you can't think of them as lateralized, which you can do for a maxillary sinus patient. This is essentially a midline structure. So you're essentially going to treat all of the ethmoid sinuses. You're going to treat all of the cribriform plate. And if there's involvement of the cribriform plate, you're going to go even further cranially into the frontal sinus and posteriorly into the dura. Because these patients can then crawl along the path of cranial nerve 1 and go intracranially. Inferiorly, you're going to go down to at least the inferior turbinate. Laterally, you have to cover the nasal cavity, the rest of the ethmoid sinus, obviously, and then at least the ipsilateral maxillary sinus in these patients because those barriers between sinuses are so fragile and very easy for spread. And then posteriorly, for an ethmoid sinus patient, you're going to cover the sphenoid sinus. And the ethmoid sinus, generally, if you have a histology that has a propensity for lymph node drainage, you're going to cover the retropharyngeal nodes in these patients. I took another slide. I'm not going to go over this. I just wanted to show you some normal anatomy. I know we showed this in a previous talk. This is, again, I borrowed this from Dr. Lee's book. I think it very nicely shows all the cranial nerve foramina that you need to be aware of when you're thinking of sinus patients. And so I'm going to end by this is kind of another complicated patient fitting for this session. So here's a 72-year-old guy who presented with a very large sinonasal cancer that involved essentially almost everything, right? So in this patient, the tumor involved the nasal cavity, ethmoid sinus, sphenoid sinus, orbit, maxillary sinus, and extended into the anterior cranial fossa. So the patient was taken for endoscopic resection. And at the end of time of endoscopic resection, essentially the pathology came back as a neuroendocrine carcinoma. And so, they actually decided to not go into the anterior cranial fossa in this patient. Had this been a different histology, we would have put this patient through more surgery. So have a neurosurgeon join in and do a skull-based resection, an anterior cranial fossa resection, and then the sinus surgeon doing an endoscopic sinus resection, and then a head and neck surgeon doing a neck dissection. But given that this was a neuroendocrine tumor, we felt that, this patient was probably best served by non-surgical therapy, similar to the small cell of the larynx patient that I showed you. And so this patient essentially got this R2 resection, and the patient was then started on chemotherapy. So this patient then started on 2 cycles of cis etoposide, and then radiation was, this started immediately right after surgery, and then radiation came in about, about 5 weeks, 5 weeks post-operatively in this patient. And so I'll show you the volumes, but this is, when you see these T4, sinonasal cases, it becomes exquisitely hard to go to 70 gray. And that's the point I wanted to make. And so oftentimes you're going to be limited by just, normal anatomy. So particularly, generally the globes, the optic nerves, the chiasm, and the normal brain are going to be structures that are, and the temporal lobes of the brain are going to be structures that are going to preclude you from going to 70 gray up front. And so oftentimes, especially if I know that the disease is going to be chemo and radiosensitive, we'll start with an initial plan that goes to 60 gray and then plan for a sequential boost to the gross disease. And what I like about this approach is you get to see the tumor involute during treatment. So generally in these patients, what we'll do is we'll start with an upfront plan and do a planned simulation around week 4, week 5, with a planned MRI also done at week 4, week 5 to see the involution of the disease, to then design essentially a radiosurgical boost. So this is our preferred approach here at UCSD, and I think it's done at many places. You can certainly say, what about protons? I will tell you that I find protons to be very challenging in sinonasal cases for 2 reasons. One, unlike photons where, the dosimetry with air, air tissue interface is robust and not variable depending on sinus fillings, proton dosimetry is highly variable with your sinus content filling. So, unfortunately, when you're treating sinonasal patients, you can't control for that day-to-day sinonasal content, right? Because these patients will develop tremendous sinusitis during therapy with sinus filling. And that day-to-day variation in sinus filling can really impact proton dosimetry, which is why I'm not a huge fan of protons in this situation. The other thing that I'll say about protons is, the Bragg peak with protons, as you know, is on the posterior edge of the beam, where you can get a very good Bragg peak. It is not at the lateral edge of the beam. So the penumbra laterally is very similar to a 6 MB photon beam. And so in sinonasal cases where, you're treating something right, in your nasal cavity, in your ethmoid sinuses, between your orbits and your brain, the dosimetry here can be very tricky, and you're oftentimes either covering, you have very poor coverage to meet dosimetric constraints, or you have very good coverage and you're blasting through your dosimetric constraints. So I actually find photon-based plans are generally better for these patients. And I'm going to kind of walk you through my contours here. So here, ignore the contour in orange. The contour in orange is pre-chemotherapy volume, and then he actually had involution of disease. But this is the initial external beam volume. And so what you can see here is essentially 2 volumes. The purple volume is 54 gray, and the pink volume is 60 gray. And what you see here in green is the gross disease post, after that second cycle of cis etoposide. In this patient. So you can see here in this patient, I'm treating the frontal sinuses. You can see that I'm covering the dura, given that this patient had intracranial extension into the anterior cranial fossa. Same thing here. You can see the 60 gray volume and the 54 gray volume, and you can see that that 54 gray volume is in dura. And in areas where there was gross disease previously, you can see that that volume is very generous. So down here now, you can see at the level of the cribriform plate ethmoid sinuses, here's the gross disease. I'm treating the entire sinus right there. I'm treating bilateral cavernous sinuses right here. And in this patient, because there was anterior cranial extension, middle cranial extension here, we're actually treating the sphenoid wing here in this patient because the patient actually had known dural disease pre-chemotherapy right in this location. So you can see that that dural margin here is now getting 60 gray and 54 gray. Down here at the level of the maxillary sinus, You can see that, covering the ipsilateral maxillary sinus very generously, and also, covering the contralateral maxillary sinus just because this disease really approached midline, as you can see here. Here's the disease right there. You can see the sphenoid sinus is being covered, and you can see that the skull base is being covered very, very generously in this patient. Given that this patient had neuroendocrine histology, we did elect to cover lymph nodes in this patient. And so you can see now here in this patient right here now, at the bottom of the maxillary sinus, you can see covering the nasal cavity, nasopharynx, and skull base generously here. Coming down here, covering the top of the hard palate. And you can see also now starting to cover buccofacial nodes, retropharyngeal nodes, and level 2 nodes. And down here, you can see, this patient has a lot of dental artifact, but you can see, again, covering those buccofacial nodes that we covered last time and covering the cervical nodes. And in this patient, given the extent, anterior nasal cavity extent, covering 1B nodes. So you can see very, some sagittal volumes here. I just wanted to kind of show you here. So you can see here, essentially covering the skull base, wrapping around the orbit, covering the maxillary sinus, wrapping around the floor of the orbit, and then obviously covering all of the neck here. Again, here showing you the same thing, showing this very good coverage of the skull base and the paranasal sinuses right here. And again, showing you, here's the gross disease, and here you can see the volume getting 60 gray around the gross disease. And here you can see the volume getting 54 gray, so going all the way into the frontal sinuses right here and covering the skull base. So at week 4, I re-simulated the patient to plan for this radiosurgical boost. And so here is the residual disease here. So what you see here in yellow is the residual disease, and now you can see this volume around there. And you see 2 different colors. You see the red color here and this magenta color here. And this is essentially me arbitrarily dividing the intracranial component, and then coming down here where I felt, here's the upper intracranial component near the globe and the optics, essentially, and then here coming down below the optics, essentially. And you can see this volume here. And I wanted to show you kind of what this looked like sagittally and coronally, and you can essentially see I made this arbitrary line here. Here's the cranial volume, and here's the caudal volume. And when I designed the radiosurgery for this patient, this is modest radiosurgery, right? So I've already given 60 gray. I just need to get to a 70, EQD2 of 70 gray in this patient. And can I do that safely? And so this is what you can see here in this patient. So you can see cranial volume getting, 7.2 gray in 4 fractions versus the caudal volume, getting 10 gray. In 4 fractions. And really, essentially, this was a completely arbitrary decision, not based on tumor, but based on anatomic location and wanting to keep my optic nerves in the globes within tolerance for this patient. So here's a great example, I think, of a very complicated sinonasal case. I'm going to end there. I'm sorry for going over a little bit, but I'm happy to take any questions.
Thank you so much for that great lecture, Parag. Really, really comprehensive. We have a few. So going back to the thyroid case, someone asked, were you concerned with the healing of the wound? Because you started the radiation earlier than what we usually do.
You're absolutely right. So I'm always concerned about the healing of the wound. But I will say that I think, again, I do a lot of high-risk oral cavity cancers. And so the higher the risk of both local regional recurrence and distant recurrence, the faster I want to start their therapies. Now, when patients develop, so oftentimes the biggest thing that you get, especially in wound healing, is that they'll have a small fistula, especially after, large flap reconstructions. So something that we talk to our surgeons very, very closely. I will actually say that it's our surgeons who really push us to start postoperative radiotherapy. And fully being mindful that this may delay wound healing. In most cases, I find that these small fistulas will heal by secondary intention. We certainly have had cases where they've not healed or the flap has dehisced. And in those patients, if they have a CR, I can always send them to either hyperbaric oxygen, or the surgeons will go back and revise their flap 6 months or a year down the line with cancer control. And so we essentially are prioritizing cancer control over wound healing in these patients. But certainly, all of these cases, I will tell you, when I'm starting earlier, it's because the surgeon is at my, on me to get this patient started as soon as possible.
Yeah. Oh, thank you for that. And we have another question. Like, for one of our attendings, we have a case in the Philippines for a recurrent papillary thyroid CA, status post thyroidectomy, status post multiple RAI, and the dose has been maxed out, and status post radical neck dissection for recurrence, and now with recurrence again, an ulcerated neck wound. What treatment options would be available for this patient?
Oh, gosh. So if that ulceration is tumor, I will usually treat those patients with a definitive intent. Now, I am very, very mindful of the fact that sometimes when these patients have ulcerations, it is the tumor that is essentially holding, plugging the hole, right? So you have this tumor that's essentially, especially if it's eroding into the vasculature, I'm very, very mindful of that because those patients either need an endovascular evaluation up front to put a prophylactic stent in those vessels. If there's a major vessel in that area that I'm worried about, because we've certainly had cases, including myself, where I've treated the cancer either with a palliative course or a definitive course. The cancer has responded to radiation, and then the patients, had a sentinel bleeding event. And so that's the only thing that I would say. If it's just an ulcerated wound that is not involving vasculature, I will either consider a definitive or a palliative course in these patients. I find that if it's just tumor that's causing the ulceration, oftentimes, they'll actually heal depending on where you are in their journey. If it's completely large, dehisced, ulcerated wound, that's not going to heal. But if it's a small volume of ulceration, those patients, I often find that the skin actually heals eventually as you treat the tumor.
Thank you so much for that. Are there any other questions? Wow.
I just wanted to say, as a resident, and a lot of this stuff is pretty advanced, but I think one of my main takeaways whenever I treat a thyroid case is to always cover that TE groove.
Yes.
Like, you don't always do that for other cases, but for thyroid, you always need to cover that because that's where you get these failures. And if I had an image right now, I would show you exactly what I mean. Like right where that esophagus is, you want to like hug that every space of it.
Yeah, no, Ben, thank you for that point. I mean, I think that is such a important point. And so because, I think inherently as radiation oncologists, we're constantly trying to spare things, and you want to spare the trachea, and more importantly, you want to spare the esophagus, right? We hammered that into you as residents, saying that swallowing function is linked to the dose to your swallowing structures, including, your cricopharyngeus and your esophagus. But this is one case where you really cannot spare the esophagus. And just have to cover it, because if you don't cover the TE groove, they will all just fail there.
Mm-hmm. Yeah, so right here, the red arrow's pointing kind of right to it, and then you're basically contouring everything except the esophagus. It's right there.
So,
well, I thought this was a great lecture, Sanghvi. Thank you so much.
All right, my pleasure.
Thank you, Dr. Sanghvi. This was a really good one, very comprehensive, and thank you. Thank you for everyone for joining us, even if we went over our time, and everyone still stayed and listened and have really interesting questions.
All right, thanks everyone. Have a good morning. Bye-bye.
Bye-bye.
Thank you.